All right, so I want to welcome everybody to today's Grand Round session. It is February 2nd, and our code for today is 1008-7616. I'll be putting the information here in the chat in just a moment as well. But please remember that if you are interested in CME credit, that you do register before midnight tonight. Next slide. So for those of you who have not yet used the new CME system, I guess it's not really new anymore, but you'll want to make sure that you register your email address with the phone number listed there. And then once you've done that, from that point forward, you just need today's activity code. You'll put attend and then the code number, and you'll text that to the number. So if you have any issues with that all, please just be sure to reach out to me and I'm happy to help. Next slide. We want to thank everybody in advance as we go ahead and get started. If you could just make sure that your microphone is muted, that way we don't interrupt our speakers here. Also, if you can remain attentive and engaged in the session. They have mentioned that if we could put any questions or comments in the chat box, we'll be taking a look at that towards the end of the session. And then I'll also be highlighting some information on the evaluation. I'll put the link in the chat box there for us as well as we get to the end. So if you could help us out with that. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we want to make sure that you're aware that we are partnered with the South Central AHEC. Our department's mission statement is listed there for you. Next slide. Also, for those of you who, again, if you're claiming CME, you are able to view your transcripts at the CME website listed there. And if you have any questions or issues with that, reach out to them, or you can also contact me as well. Next slide. We also do offer AAFP credit for this session, so please make sure that you do have your CME transcript available to request that. But if there are any issues or questions, please contact the AAFP or you can reach out to me. Next slide. We want to make sure also that we mention to our attendees that we do try to address the nationally established physician core competencies that you see listed there. You can take a look at those. Next slide. We also want to mention that our presenters have no financial relationships with ineligible companies to disclose. So we're going to go ahead and get started here. I'm going to introduce their presentation here for you, and then I'll let them introduce themselves. So they are going to be discussing with us today, refining the rainbow road in medical education, dispelling myths, erasing stigmas, and promoting LGBTQA education among residents and faculty. So I'll let them get started.
Thank you so much. So hello, my name is Beth Wueste. As we already noticed, we have no money, so therefore no disclosures. Yeah, I think you had a handout provided to you, but today we're going to take a look at a few items that are in fact related to our community, the LGBTQAI+ community, in an attempt to dispel myths about what gay is and what it is not, looking to erase or at least acknowledge stigmas that do exist through self-reflection in the definition of terminology, concept, statistics, and we'll finally be reviewing some associated behaviors, preferred behaviors that are associated with our community. Finally, why we're really here is to, in fact, promote the education among interprofessional teams by identifying some effective techniques and strategies as far as communicating with our population, working with the patients, your peers, anybody in the IPE teams, and doing our best if we can to just enhance your knowledge, skills, and attitudes as it relates to the LGBT community of all ages. So briefly, so my name is Beth Wueste, and I have actually been a medical educator here at UT Health San Antonio for about 22 years. I've spent the majority of my time watching our medical students into residency, then fellowship, and eventually practice with hundreds of thousands of dollars in education, a handful of experience, and an eagerness to change our world. And I appreciate that. However, with an infinite amount of knowledge needing to be taught in a finite amount of time, it's only to be expected that many important topics, such as social aspects of people and medicine, are missed in our formal education. So today we're going to take the time to fill in some of those gaps with you. We're going to take the time to look at ourselves, our current social makeup, and how we can build better relationships with all members of the healthcare team, such as students, nurses, residents, fellows, faculty, staff, and all in the eventual hope of impacting and having a more positive impact on the patient. I am not a gay educator. I am a medical educator that happens to be gay. In fact, I spent the better part of my career here at UT Health in the closet, happily in that fact. Never did I imagine I'd be giving all of you a lecture today on LGBT education. So now I, funny enough, serve as the Pride Group mentor, the Trans Affirmative Care Team developer and mentor, chair of the LGBTQAI learning community for the Association of Pediatric Program Directors, member of the UT Health Diversity, Equity, and Inclusion Committee, member of the newly found University Hospital LGBT Focus Committee, a member of this amazing group that's going to speak with you today that's dedicated in the creation of competencies, curriculum, and assessment tools for this specific topic in medical education. This picture, I always like to be a little more personal, but this is my wife, Sarah Wueste. She's dynamic and smart and funny and brave, and in the end, she is in fact all mine, so you can't have her. She, along with my family, have accepted me for who I am. And that already makes me one of the 1% in this conversation. And so they have accepted me for who I am, and that's why family is so very important in this topic. And so I want, and my group would like to begin today by thanking each of you for accepting us today, for your time, and for your openness and your interest in learning about how to bring diverse groups into your world. This is my killer, amazing, wonderful rainbow mafia of a team. Dr. Roth and Lurie is the medical director in the Carolinas. He is actually not here today. We do apologize. He had a last minute family emergency. With us, however, is Dr. Lauren Roth. She's the assistant professor of pediatrics, Children's Hospital at Montefiore in New York. And after her is Dr. Brett Cooper, the assistant professor of pediatrics, specializing in adolescent care at UT Southwestern Medical Center in Dallas. And so the ultimate goal, right, today isn't just another set of CME credit. Let's hope anyway, right? That's definitely an added perk, like tacos, but it is not why we're here. And so with that said, to reach the ultimate goal in teaching and learning about our community within healthcare, we must first educate ourselves on the available information, and through that journey, address our own biases through true self-reflection. Once we begin addressing our own biases, we can objectively educate our trainees, our nurses, our staff, and begin planting that seed, or what we'll call the LGBT data, insights, and base education. And finally, we need to develop the skills to help our interprofessional teams, patients, and their families through open and neutral dialogue. So the ultimate goal is to change how we communicate on the topic of LGBT. And today we will begin that conversation in what we would consider our safe space. On that note, we start with learning objective 1, discuss why training for our community in competent care is so important. And we will begin with Dr. Brett Cooper. Dr. Cooper, just tell me, oh yeah, you can go yourself, never mind, go for it. You're muted.
My bar went away. So technology, and we are this far into doing Zoom. So I will back up because clearly we know what we're doing. So I think part of what I'm being asked to speak about is the why should we do this, right? And so the Joint Commission, which is everyone's least favorite buzzwords, say that the lack of culturally competent providers is a barrier to healthcare for LGBTQ people. And, much like Beth, I am happily out and gay and proud and all of the other things that go along with that. So I have personally experienced providers who, fortunately, I think this is one case where maybe you want to be in the 1%, that I've not had any negative experiences. I've had one where I just provided some education from naivety, but that is not the reality for most of our peers, and that's why we're here. So there we go. So there really is this like paucity of training in this area. And so I want to call your attention, remember, to this little triangle in the corner. As we think about medical education in particular, that a lot of the things that all of us learn really are about attitudes, the knowledge of why you're here, and then skills, whether that's procedural or non-procedural. And so really, when we talk about this topic, you have to incorporate all three of those things. And so back in 1991, there was a study done looking at homosexuality, which is a word I try not to use anymore, but it's out there. And there was really this like very minimal average of curriculum, right? So you think about all of the 4 years of medical school, 3 hours is like 1 day, if that. And so, and a lot of that, which I'll get to in a minute when we get to 2011, because it has some relevance for me. And then in 1998, again, half of schools with no content, and really the amount of content had decreased to about 2.5 hours. And 2011, two fabulous human beings out of Stanford published a study that they surveyed all of these DO and MD schools, and the median content, we now got up to 5 hours, but still 1/3 of schools reporting 0 hours. And I can say that as a proud 2011 medical graduate, so around the time I was in schools when they were collecting this data, we maybe had an hour, and it was basically that gay men get AIDS. And so that's really what your content was, is HIV screening. And maybe if you were lucky, you got a little bit more, but that was basically it. And the resident, like how we look at resident knowledge is much harder to assess because it's a less standardized per se curriculum across residency training programs. But the ones that have been done show that residents really don't get a whole lot either, unless you're at a place that has a specific LGBTQ program or clinical programs and things like that. So when residents are surveyed, they also demonstrate that and say this like, I don't know what to do with these people. And my response is, they're humans, treat them. There's nothing special you have to do when I walk into your office, just talk to me. So in an internal medicine study, residents said they were uncomfortable initiating conversations with patients. They were more likely to consider a sexual health as unimportant. And then just this general lack of knowledge and caring for them. And then in emergency medicine, there was this taking a history is more difficult. And my response is, it's a history, like literally just ask why they're there. And then do what you need to do, because as Beth so eloquently said, she is not a gay educator. Like, I don't have a gay knee injury. It's just a knee injury. And so like, treat it. So that's where this is really disconcerting to those of us in medical education. And again, why we're here. So some of the challenges. So there could be a lack of an effective curriculum. And so there's not this like, when a family medicine resident graduates, I will say you all were at the forefront of a lot of this. And there is actually an AAFP document about knowledge, skills, and attitudes for family medicine residents. So I will just give a kudos to family medicine and their kind of foresight in this area. And so you all could look that up if you wanted to. But when we look at other specialties, that is non-existent. There's an absence of faculty, right? So you need people who can teach this competently, and they're not just like winging it to meet certain checkboxes. There's this lack of instructional time. So even in residency, you only have so many didactic hours. There are people who might be on night shifts, so like they're not here right now, or they're on vacation, or whatever the case might be. There's these perceptions. And so do your faculty even think this is important? And so if they don't, they might just blow it off or say like, we don't need to teach it, or like, we'll just let these people over here teach it. National examinations. So do your licensing exams include questions about LGBTQIA plus people? Do your shelf exams in medical school. I can happily say that I took my adolescent medicine board exam in August of 2020, and I had 5 questions that did not involve HIV for LGBTQ patients. And so was proud to see that they were relating to other human being things that go on. There are scarce resources that are accurate. So again, I can find you a whole bunch of resources that are misinformation perhaps, or trying to say like, we should do conversion therapy on LGBTQ people. So trying to find really accurate ones can be difficult. And then lack of role modeling. So, I think back to when I was a medical student, I can tell you there were this many gay faculty, LGBTQ faculty that I at least knew of. They may have existed, but at least that I knew of. And so I think it's really important when I was out to peers in medical school, but was very much out as a person when I got to residency and could care less what people thought. And so to me, it was really important to be that role model for other students. So even if they don't tell me they're LGBTQ, they at least know I am, and they can know that there's a safe person in their sphere that they could talk to if they needed to, or say like, look, you can be gay and be a resident or be an attending, like it's fine, it's not a big deal. There we go. All right, so what are the consequences when this happens? So if we have stigma, we have discrimination, we have the like, oh, you're gay, like I don't know what to do when I walk in the room and talk to you. That can lead to acute stress in the moment. So certainly like now I'm getting anxious because I'm like, what is this person doing? Like, why are they sitting halfway across the room? What's going on? And then there's this chronic minority stress that's been well elucidated by several prominent researchers that is both internal and external. The impacts of that stress then lead to obviously mental health concerns potentially. It can lead to physical health concerns. So if my blood pressure is constantly up, my stress hormones are circulating and causing a bunch of damage. It can impact access to care. So like I could care less. I just show up and see somebody, and if they aren't really into the fact that I'm gay, like whatever, we're just going to plow through that visit and I will make you really uncomfortable. But that's not the case for everybody. And so some people are like, well, I only want to go to like this primary care doctor because I know they're gay and I'm not going to be treated bad, versus I just pick a name out of a directory and hope that it works. And then what is the quality of care, right? And so if I am, for example, like if I needed to be screened for STIs and maybe, that man who has sex with men, you don't swab their rectum because it's uncomfortable for you to ask. You might miss an infection that's in their rectum, but they have negative urine chlamydia and gonorrhea testing, for example. So they're not meeting the quality of care that that individual deserves. And then all of that puts together leads to a lot of these inequities and inequalities in health that, much like we're having a lot of conversation in medicine around, I think of things like, should we, when we say that like African Americans have a higher prevalence of X condition, it's not because they're African American necessarily. It's because of the other social determinants of health that maybe impact that racial group, which then lead to that higher prevalence. So a lot of these things are not just because like mental health is more prevalent in gay people. It's not because they're gay. It's because of all these other things. And so if we can impact the bottom box by reducing things upstream, where my camera is, then you're not going to say gay men are at a higher risk for X because of the fact that they are, for example. Sorry, I'm not leaving out folks like Beth. It's just gay is easier for me to use. So we treat all LGBTQ people across the spectrum. The legal put this out in 2014 that was looking at when healthcare isn't caring. And this has been replicated, for example, if you look at the US Transgender survey specifically as well, for trans and gender diverse folks, this type of data has been replicated across multiple studies and populations. Maybe it's because they're using the same people, I don't know, but it certainly is there. And so look at the rainbow mafia as a whole. There are people who would like refuse to touch them. And I was like, you can touch me. Like I don't seep anything out from touching me. They blame them for their health status. So there's the like, I don't know if a lot of you have heard this come around when HIV pre-exposure prophylaxis came out. There was a lot of people who were referred to as Truvada sluts because they were on PrEP and then having sex with multiple partners. that doesn't get us anywhere to be like, look at you and what you're doing. Shame on you. You just wouldn't need to be on PrEP if you weren't sleeping with people. They use harsh or abusive language, which I would hope we're not doing that to anybody, but again, it happens. And then trans patients specifically reporting being harassed in a doctor's office. What I think doesn't always come out in these studies, but is an important thing to think about, is you can be the most affirming and welcoming and non-judgmental physician, but if your front desk is the rudest people on the planet, they are not going to want to come back to your office specifically because they've already been harassed when they walk through the door. So what these studies don't elucidate who did the harassing. So just keep that in mind. I like to put that asterisk because it may not be the doctor specifically. But again, this is looking at the whole health system. And then they flat out being denied medical care. And I have seen this with some of my pediatric patients. When I see my trans patients, their pediatrician has been like, well, you're trans, like, I don't know what to do with you. You're going to need to find a new pediatrician. I'm like, they're a person. So again, people are flat out denied care. And in some states, ours tried to do this last year. They tried to make this legal to deny care based on your religious or other sincerely held beliefs. And so I think it's a hot topic to think about, but at the end of the day, we're all healthcare providers in some capacity, whatever that is. And my personal beliefs do not belong in the exam room. Just my personal thought. And then when you look at these barriers, this is old data, but I would say still holds true, even in 2021, 22. That by and large, transgender or gender diverse people as a whole are the ones who delay a lot of medical care because their LGBTQ state is usually more obvious to the naked eye than like I could walk in and if I don't tell you I'm gay, I do a lot of hand motions, but in theory, you may not know I'm gay unless I tell you. And so, Beth, I see you smiling. But trans people, they look different, right? When they walk in, some of them. And so it's very obvious to the person who's staring at you. And so they tend to delay care more often. And then there's LGB folks in the middle, and then heterosexual folks still delay care for whatever reason, financial, transportation, et cetera, et cetera. But all of those non-medical things still impact LGBTQ people as well. Lack of health insurance, lack of transportation, lower paying jobs, unemployment, et cetera, based on just literally who they are. So this is a multifactorial thing. So if we kind of put all of this together, those of us in the medical field have this lack of education, lack of clinical experience, that then leads to negative experiences when they do come in, potentially. Then the next time they're going to just put off and put off and put off going to see care until it's too late. And then that leads to poor health outcomes. So when we think of those outcomes, here's the overall picture. Mental health, suicidality, non-suicidal self-injury, higher rates of substance use to cope with it, bullying, higher STIs because they're not coming in to talk about PrEP or get screened and things like that. Eating disorders, because especially in the gay male community, there's a big body image perception that like you're not the best gay male unless you have abs and a six-pack and you look hot. People aren't going to want you. And that also permeates through the other pieces of the rainbow. And then family rejection also plays a big part. I also was very blessed, like Beth, in the 1%, and I mean that very sincerely, that it's probably maybe we're getting higher, Beth, maybe 2 or 3% now. But my family was like, we were just waiting. And so it was no big deal. My husband that I've been with for years, like, was just accepted like my brother's wife was. And so we're very lucky, and that leads to decreased stress in my life. And I can't even imagine what that would be like. So family rejection also plays a large part in this as well. So I've done enough talking, and now I'll let somebody else.
I was like, how do I get my power back? I found it.
I just gave it up to you.
Thank you, Dr. Cooper. You're so kind. All right. So obviously, I don't think any of this is shocking information for anybody. Maybe it is. I'm always taken aback a bit when people ask me questions in general. But what we're going to do now is a little bit of that dispelling some myths idea. And so we're going to take a quick quiz. If we were together, I'd actually have you take a quiz. But in fact, I just want you to do it in your brain. You can write it down if you want to. So I'm going to put some different comments up, statements, and I want you to think about it if you think they're true or if they're false. Okay. And I'm going to go fairly quickly because we have a lot of fun stuff to talk about. So I'm going to put it up and in your brain, true or false. Being gay is a choice. Lesbians and gays are always easy to identify. All lesbians are butch or femme. All gay men are flamboyant. Same-sex parents harm their children. Bisexuals are confused. Transgender people are attention-seeking. People become homosexual because they were sexually abused as children or there was a deficiency in sex role modeling by their parents. Openly gay teachers, doctors, professionals, and other role models are dangerous because they will try to recruit people into homosexuality. One person always plays the role of husband and the other the wife in a gay relationship. Children can't know if they are transgender until after puberty. So I do this quiz, funny enough, these are probably the most typical stereotypes we are given, and I will let you know they are all false. Now we can go back and forth about them in general. As far as no one is born gay, that's probably the one that comes at us the most. We're not going to split hairs on this, but we can probably do it after the fact if necessary. But I can guarantee you, most of us didn't choose any of this. We were all born this way. So whatever that means scientifically. However, these stereotypes have done incredible damage to the medical community, to physicians, to healthcare providers, as well as your patients. When we have same-sex couples come into clinic and the first question out of the provider's mouth is, which one of you had it or bought it? This is a problem, and these are actual statements that are made to human beings walking into a clinic. So like I said, we're going to be dispelling some myths, right? So the next one is the gay myth of coming out. And quite frankly, let me just say this. There's a great TED Talk by Ash Beckham. She's hilarious. Check it out if you can. It's free. It's online about coming out. The point I want to make here is that we don't just come out once. So I have to come out every single time I go into a group of people in South Texas and say, this is my wife, right? I have to come out every single time I don't fit the status quo. And that stress is incredibly hard because I have to also think about my safety. I have to think about my wife's safety. I have to think about all of these things. And so, as I mentioned at the beginning, I stayed closeted for a very long time here at UT Health. Why? Because up until 2 years ago, I could have been fired for being gay. It was written into UT's bylaws. It's that new that we can actually be out and not be fired because of who we are as people. Remembering this as you're doing training or you have trainees that may come to you, we'll talk about this, or you have patients that come to you and they give themselves and let themselves become out to you. Be very careful in how you respond to that. Don't immediately think it's a great thing and that it should be shared. It is still a private conversation. So these are used often in our trainings. This is the genderbread person, and or the more updated version is the gender unicorn. We often use this really, and so we're giving you tools to use with your trainees, your students, your patients, even, or yourselves. But I think what's really important here is that we talk about the difference in the conversation of gender identity, gender expression, sex assigned at birth, our emotional attractions and our physical attractions. And so our sexual orientation is the preferred term used when we're talking about an individual's physical or emotional attraction to the same or opposite sex, right? Whereas our gender identity refers to our person's innate, deeply felt psychological identification to a gender or a gender fluidity. Our gender expression is how we outwardly present our gender. And then our biological sex, I think we can all grasp onto is how we were born, but may not be how we identify. And so that's a very important conversations to have with your trainees when they're asking these questions. That terminology does become very important to the community. So we talk a lot about Mythbusters, and we talk about implicit bias and micro and macro aggressions that are often seen both within the LGBT world as well as systemic racism as a whole in the world. However, the first thing we have to talk about is, what is it, and are you biased? And the answer is yes. Like, we're not going to dig into this, but yes, we all carry biases, and they're not all malicious. Most of them are just roots of where we're from. And or what we see a lot with transgender education is a lack of exposure. So if you've never met somebody transgender, you don't really know how to ask those questions, or maybe you're afraid to offend them. And so instead you just avoid conflict. And so as we talk about these biases, we really need to self-reflect on what we may have and how those things may be affecting our care. So as a lot of people know about the implicit association test. So Harvard, U of Washington, several universities got together to do this massive social experiment. And so you can go online to this website and you can test all kinds of biases. It's anonymous, but it's kind of cool. They add different ones all the time, but the Sexuality IAT lets you know where your biases may lie. So I like to put myself on the grill. My bias is against gay men. I have to actively put myself in their shoes and stop and get rid of the stereotypes that I grew up with as a West Texan about gay men, even though I'm a lesbian myself. And so I think it's very important to be honest about how you feel and what you think, and then the things that you do need to overcome to be a better provider, a better person, a better whatever to whomever you are treating and taking care of. So I want to have a 1 second thought, and we talk about bias a lot. So I'm going to put up some words. And again, I want you to write down, if you're tactile, I want you to write down the first thing that pops in your brain, like the very first thing. Otherwise, just be aware of it, right? So really think about what's the first thing that pops up as we start to talk about things. And then I'm going to show you some answers that we've received over time. So the first initial thought, and what I want you to think of, first word that comes to your mind when I say lesbian. First thing that comes to your mind when I say gay. First thing that comes to your mind when I say bisexual. First thing when transgender. Straight. African American. Caucasian. Millennial. Baby boomer. Police officer. Muslim. Physician, nurse. So why do we do this? Because often when our group is in a training session, we really want to dig into those biases, right? And so these are the answers that we've received over time, right? So the first was lesbian, flannel, short-haired dyke. Good dresser, promiscuous for gay. Confused and young for bisexual. Cross-dresser, he, she. By the way, both absolutely inappropriate to say, but not to think, because they are your thoughts. Straight, normal, accepted, boring. African American, angry, athletic, soulful. Caucasian, racist, majority. Millennial, multitaskers, entitled, lazy. Boomers, workaholic, unadaptable to change. Police officer, brutal, quotas, protector. Muslim, terrorist, Arab, oppressed. Physician, infallible, superior intellect, unwell. Nurse, female, failed MD, floor boss. Now, why are these really important? Because they're honest. They're people's honest answers as to what came to their mind when they first heard it. And when we start talking about overcoming that, we need to all understand that our residents, our students, our faculty come to us with these. They come with these stereotypes. And although they may not say it in our professional groups, they are in fact thinking it and saying it in their social groups, which will in fact translate at some point into the other arenas. And as Dr. Cooper mentioned, if we can't get rid of these stereotypes and we can't talk about our biases, these will impact our psychological mental health needs in the community and of our peers. I get to do the fun ones, right? So I will give $2 to anybody who can tell me what all these letters mean. I laugh because I can't see anybody's faces but my own people. And Dr. Catterndall, I probably messed up your name, sir. I apologize. However, This is our alphabet mafia. And here's what's even funnier. This isn't even all of them. And so I'm often said, this is my lovely father who's very accepting, but he goes, if you don't know what they mean, how are we supposed to know what they mean? And I take that to be an impactful statement. And it's true, right? If we've made it so complex that even our own community can't figure it out, we should probably help others, right? So let me be nice and let you know what they all stand for. So they in fact stand for lesbian, gay, bisexual, transgender, transsexual, queer, questioning, intersex, intergender, asexual, ally, pansexual, and two-spirit. We're not going to get into what all of these things mean. But what I will tell you, if you are curious, you can raise your hand and I'll go into all of them. But what's really important here, and what I hear often is we should have an directory for physicians that they're saying they're competent and they're this and they're that. No. The community doesn't work like that. We don't want you to raise your hand and be like, I like gay people. Like, that's weird, right? What we want are symbols. We want you to understand what these letters mean. We want you to understand these symbols that you see on my page, right? So the top right, in mine anyway, is the pride flag. The pride flag has in fact evolved from get to now. It now actually includes a white, a black, and a brown stripe. The black stripe actually was supposed to be removed from the flag once we eradicated AIDS. We have not done such. Now it is encompassing of our brothers and sisters of color. The one behind it, the one below it, is the pink triangle. This was placed on gays and lesbians during the Holocaust to identify those folks. The lesbian community has taken it on to be theirs in some empowering, weird way. The bottom to that is the transgender flag, as you can see. To the next of that is your HRC, or Human Rights Campaign sticker. I have one in my office. If you put one in your office, it means a lot to people, quite frankly. Below that is the DOMA flag, or the marriage equality flag. To the very top is the GSA flag. A lot of people have pride groups, have safe space groups. They often affiliate with this or those colors. And what this means is this shows people that you're a safe space, that you're an open space, and your clients / students / patients will know immediately upon arrival, if you have one of these on your badge or in your clinic, that they are okay and they are safe to talk to you. We talk about pronouns. We're not going to get into pronouns completely, but here's what I'll tell you. In pediatrics, we give all of our residents a Pride Caduceus button, and we give them a pronoun pen. And then we let them pick their pronouns, she, he, they, thems, or write in your own pronoun to put on their badges. We do not call them preferred pronouns. We just ask, what are your pronouns? Often you don't even need to ask your patients this. What you say is, hi, my name is Beth Wueste. My pronouns are she, her, hers. And you just stop talking. And it's enough to let them know they may not know their pronouns yet, but they definitely know that you're open to it and they appreciate that. And that's the world as a whole, quite frankly. And then, as we always talk about, the transgender world is huge and it falls under a massive umbrella. And so to try to condense it into one lecture is never going to work. So here's what the ultimate goal, as we talked about, is respect. Straight up. Just respecting people for where and who they are. Dr. Cooper can speak to this, but children know that they're transgender or know their gender difference way before puberty. And so if they come to you and they have that conversation, you just listen. You listen and you guide and you help. You don't talk them out of it and you don't tell them that they don't know because they're too young. They know if they're in the wrong body. And so as we talk about this, the one thing that we will talk about is, quite frankly, as we've alluded to, we're all human beings and we all look the same upon birth and death. Inside, we all look the same. And so as we start talking about those patients, those learners, those faculty members, we include them as human beings because ultimately that's it. And then we learn from them. Dr. Cooper alluded to being gay in medicine, and quite frankly, it is in fact its own beast. When I first started here at UT, there were a bunch of us. However, we hid. So we had a pride party at one physician's house. It was quiet. Nobody talked about it. That physician had been with his partner for a little over 20 years and nobody knew. He never spoke about it because when he was going through residency here at UT, He openly said he was gay to somebody, and they immediately told everybody that he had AIDS. And when that happened, that decimated him. So what I want to talk about is you start to bring these learners in, and although we are changing and becoming more open, there are going to be a lot of people who are very afraid to be out, whether it be on the interview trail, whether it be when they're rotating with you or when they become one of your fellows. Again, you don't have to just throw a big gay pride party for them, but at the same time, make sure that they know that they are safe and that you don't believe just because they sit on the rainbow spectrum that they're a pedophile or that they have an STI or that they have some different mentality than you or I may have in some other capacity, because it is incredibly hard. Dr. Mark Schuster, and I'll send this out, wrote an article. He's a general pediatric physician at Boston Children's that talked about his journey, about being gay in medicine and how it felt and going through it. And I think it's really important that you read it and that you share it, because it is absolutely one of those things that we talk about during recruitment every year. How do we let our applicants know they're safe here? And this is a really big deal, but also for our residents just as much. I'll quit talking and I'll hand it over to Dr. Roth right now to do learning objective 3.
Awesome. Thank you so much, Beth. So our final objective in the remainder of this presentation will be to demonstrate educational strategies and curricular content developed to promote education to appropriately care for LGBTQIA+ individuals. Dr. Cooper talked a little bit about the 90s and the early 2000s when research started to come out about the lack of curricular hours. Now, in the last decade, a few major organizations have released recommendations to start to incorporate LGBTQ health training in medical education. And we've begun to see a shift in curricula that are starting to incorporate this material. But I will say, we're still not going far enough, but I'll go through a few of these. If you could go to the next slide, Beth. So Healthy People 2020 included that eliminating LGBT health disparities and enhancing efforts to improve LGBT health are necessary to ensure that LGBT individuals can lead long, healthy lives, things that we've already spoken about in this presentation, such as reductions in disease transmission and progression, increased mental and physical well-being, reduced healthcare costs, and increased longevity. Next slide. And the Joint Commission in 2011 put out actual topics to cover in training, which has been a really helpful guide to start to incorporate this, though many institutions still are lacking. I'm not going to go through all of these, but in general, they're just kind of topics to go through. And the AAMC put out something similarly for undergraduate medical education called Implementing Curricular and Institutional Climate Change to Improve Healthcare for Individuals who are LGBTQ+. The ACGME still is lagging. Currently, there is no requirements from the ACGME that medical schools or residency programs must devote curriculum hours to LGBTQ healthcare. Historically, there have been no formal educational standards to follow, and it's something that we're all actively advocating for. The most recent updates were on July 1st, 2019. Where the common program requirements included a line that said respect and responsiveness to diverse populations, including but not limited to diversity in gender, age, culture, race, religion, disabilities, national origin, socioeconomic status, and sexual orientation. Notably, gender identity was not included in the statement, and that was really it. There weren't specific guidelines about how to incorporate any of this, about what topics to include in residency training. And in 2020, there was a great article in Academic Medicine that was a call for LGBTQ content and GME program requirements, really pushing the ACGME to release actual requirements for what topics should be included in this training. So I hope the big takeaway today is, what can you do? If you're listening to this talk, I hope you've learned a little bit, and I hope you go back and start to teach about this, because that's what's so important. Training future and current physicians is an important first step in improving health disparities, and I hope we've shown you that today. But importantly, don't wait until it's a requirement. You know, these requirements take a really long time, and there are many opportunities that you can find for didactics, for skills training, and for clinical experiences with LGBTQ+ individuals. And I'd argue that those clinical experiences are the most important and are often hard to find. So when you're thinking about designing a curriculum, or if you're here and you say, okay, we already have a curriculum in place, but you want to improve it, right? We can all continue to improve how we're teaching this topic, especially because it's constantly evolving. So consider the time, right? Every program has a different amount of hours dedicated to certain topics, and there are certain topics that are really critical in medicine. So how much time can you actually devote to this, and how can you make the best use of that time? Who are your learners? Are you going to do some kind of broad thing that will be for PGY 1, 2, and 3s? Are you going to separate it by training level? Are you including medical students? Are you teaching faculty? Because that is also so important when we're talking about role models who are going to role model this in their daily encounters. So we really need to train our faculty and clinicians. And what strategies are you going to use? So, right, a mix of skills training, of clinical experience, of didactics are all so important. Faculty development, as I mentioned, funding. That always comes up. You don't really need funding to do this. You can start to just, in your cases, when you're presenting about knee pain or back pain, you can talk about a same-sex partner. It doesn't need to be related to the case at all. And we need to get trainees away from saying, oh, that was a same-sex partner, there must be something about being gay that is relevant to the case. And it's not. And it just needs to be normal. For us who are, I'm a pediatrician, we have to talk about two moms coming into the room, and it can't be about the two moms. They're just coming in with their baby. And I think starting to incorporate some of these topics just in those day-to-day medical cases is so important. Sustainability is another huge consideration when you start to do this training. A lot of times, the way I got involved in this, and I'll talk about something I did in a little bit, is as a resident, right? And I was really motivated and passionate, but then I left my residency program, and what was a program left with? You need people to continue to do this year after year. And if you're going to make online modules, or recordings or slides that people are going to use year after year, someone needs to update them because the terminology is constantly evolving. And evaluation is something that we're, as a team, actively working on, and Beth will talk about a little bit later. But it's really important to start to think about how we're assessing learners and how we're actually evaluating our curricula to make sure we're not just teaching what we think we should teach, but to make sure that our learners are actually learning and our curricula are actually doing what we want them to do. So I'm going to talk a little bit about a curriculum I developed. And I know Beth and Brett were both so honest about why they're here. And I'll tell you my personal note, and how I identify in this Mafia is I really consider myself an ally. And that's because my brother's transgender. And he came out older, he was 21. And as a pediatrician, I kept thinking, why didn't anybody ask? Why didn't we ask? Did I miss something? I felt guilty. And I was an intern in my pediatrics residency, and I had not learned anything about what it means to be transgender in medical school, and nothing in my residency program. So I really started advocating for time to start to educate both my peers in my residency program as well as the faculty, and to make a sustainable curriculum. So we published this recently in academic pediatrics, but the reason I just want to show you this data is to show that it works, that training on LGBTQ health actually affects provider comfort, provider knowledge, provider skills, and patient care. And, of course, it's really challenging to actually show that there's an improvement in health outcomes. We hope that that's the case, but what we looked at were changes in provider comfort. So asking about sexual orientation, gender identity, specific sexual practices, medical and preventive screening guidelines, and gender affirming care for transgender and non-binary youth. And across the board, the only thing that people were pretty comfortable with already this was a 1-year curriculum. We're asking about sexual orientation. We already had pretty high percentages, but the rest were all statistically significant. And then if you go to the next slide, we also showed perceived increases in provider knowledge across the board in every topic we talked about. And finally, we asked, if you go to the next slide, about actual history taking. And after specific training and dedicated time workshopping how to ask some of these questions, we saw increases in self-reported history taking. So it really is important to do this training, but also it's important to know that you actually make a difference. And I'd like to think that we have started to, and there's a long way to go still. The last thing I'll say before I pass it off to Beth to finish is, for our curriculum, we developed competencies related to the 6 ACGME core competencies. I'm not going to go through all of these, but we wanted to make sure that our curriculum included all of the ACGME competencies. And luckily for family medicine physicians, if you go to the next slide, there already are competencies that the American Academy of Family Physicians put out, and they're focused on the knowledge, skills, and attitudes that Brett discussed earlier. So if you haven't seen these already, I really encourage you to take a look at them. And this is something that has encouraged us in the pediatrics world to start to develop specific competencies for children and adolescents, because while a lot of this is similar, there are specific considerations for our younger population, and we think it's so important to have our own competencies. So I'm going to hand it off to Beth to talk about our working group and a little bit more about education.
All right, fantastic. We're at the home stretch. It's worth all 55 minutes of CME, I'm sure. And kudos. So as we mentioned, we are a group of Misfit Toys that came together in different ways because we all have the same passion, and that's humanity. And so I am from the APPD, or the Association of Pediatric Program Directors. Dr. Brett Cooper is adolescent medicine, and Dr. Roth is the APA Pediatrics, Academic Pediatric Association. We actually came together by absolute accident, but I think that we've been able to just kind of nail it now that we're together and kind of making things happen. So our overall goals were to write competencies. So here's Brett Cooper, his adolescent group found the family medicine, and they said, nope, we can do this too. And so gosh bless competition in medicine. So they started writing competencies for pediatric patients, 0 to 17. And I love that. At the same time, Lauren, unbeknownst to us and us at the APPD, were writing curricula, patients, families, and providers. So it was a comprehensive. And then I don't believe in doing anything without an evaluation. Can you tell I'm a GME person? So I said, let's write an EPA. Let's make it happen, an entrustable professional activity. Now, most of our specialties have their own EPAs. There are a handful of core EPAs. We are blessed enough that our EPA will become a core EPA for all specialties, and it's in its final stages right now of edits. So we're very excited about taking care of the LGBTQ community. So some of the outcomes from our curriculum, as we've all started, so bringing it all back full circle, it is based on knowledge, skills, attitudes, and behavior. So much like our milestones, and I know you all love them, are behavior-based, as is how we tend to assess learners. So our curriculum toolkit, don't go to this link, you'll need a password, sorry. It includes cases, videos, role plays, Jeopardy, modules, didactics, OSCEs, panels. It includes the Howard Brown, the Feinway, the AAMC links to their curriculum. We don't believe in recreating the wheel. We believe in creating more wheels. So you have as much as you need for when you need it and how you need it. And then of course, the assessment tools we're using will be milestones based, but predominantly EPA based, because clinically we need to make sure there are clinical outcomes that can be seen over a longitudinal amount of time, meaning birth to death. As a physician, we can make sure your skills are staying attuned at all times. We're working with adults here. So when we start doing all of our curriculum, it's completely based in andragogy. So we're making sure that our adults need to learn it, AKA their patients, that they're learning what they feel they need and how they feel they need to do that. We believe in learning by doing. So these should be hands-on. Modules are not super effective on their own. So we definitely need some interplay there. We focus on realistic problems like, oh, I don't know, patients and their clinical concerns. We learn best in informal situations. So a lot of our residents have a hard time toggling between the idea of being a student and an employee. And we all know in residency and fellowship, they are in fact informal learners. They're learning on the job. And so this should be embedded in a constant way. And then they want guidance. They want to know what to do and what to say, and they want it done the right way. And so our education and our curriculum really kind of give that offering to both the facilitator and the student. Again, these are teaching techniques we took into play. This is the learning pyramid. So as we know, me talking at you, you're going to retain about 5% of this. I wish we were in person. But quite frankly, if you're a resident, start teaching others, and this is why the ACGME has sat on residents as teachers, so we actually absorb and keep 90% of what we're learning because we're able to give it back, right? So we hope that part of this curriculum becomes problem-based, flipped classroom style, where your residents are actually teaching it once your faculty have developed their own KSAs as they move forward. I always asterisk Kearns because in medicine, they believe that's the only way to build curriculum. But I need to be really honest, we didn't use Kearns to build our curriculum. We used andragogical and adult learning theory, straightforward. So we often are asked, where do you implement this curriculum? And as alluded to already by my panel, everywhere. It should not be held separately in endocrinology only. That's really offensive, by the way, when that happens. Like, we're more than a pituitary problem, quite frankly. So when we look at this, you have noon conferences, grand rounds like this. Kudos to family medicine for this. And a resident, by the way, is who reached out to me after hearing this grand round that we did for pediatrics and asked me to come and speak with this panel. So kudos to that resident. Put it in every rotation you have, period. Because guess what? People on the LGBT spectrum, they kind of get sick in every way. It's not specific. Make it longitudinal. So baby steps as you go, little bits at a time. Set up sim labs. Give them a comfortable, safe space to do some OSCEs, to learn how to do some things first. In terms of CME, there's only one jurisdiction, DC, that requires physicians to complete education related to this health topic. So kudos again to all of you for offering CME for this lecture specifically. You should feel really good, quite frankly. So you know all of these things, right? As educators, as providers, it is our job to be respectful and sensitive, aware, hyper-vigilant of comments, "You're so gay" being the #1 thing we hear constantly. Using inclusive language, challenging the current and the old curriculum, creating safe spaces, and being patient. But we need to make sure that we're not supporting somebody when we out them. So we do need to be very careful if that's a learner and or a patient. We don't compare stories. No two gays were made the same. No two transgender patients had the same journey. And so we don't compare them to each other. We don't assume people are gay or straight by their behaviors. We don't allow really ugly comments to slide in the professional world. We don't tolerate transgender comments. We often hear them more on the floor. Dr. Cooper mentioned front desk people. When we did a survey of our residents, most of the he, she comments were actually made by the team members on the floor of the hospital and the faculty, not by the residents or the medical students. So it was really interesting. And we don't ask super personal questions that are not applicable to what they're there for. So we don't minority tax, right? We don't have broken gay elbows. We just have broken elbows. These are ways to stand up. I'm not going to read them to you, but I do highly recommend a Upstander training for your entire department if you haven't done it, because we're not all really good at confrontation. I work in peds, so none of them are good at confrontation. So ultimately, it's a really good idea to give people the skills they need to be able to stand up and tell somebody, "You're making me uncomfortable," or "That's a really ugly statement." But you have to kind of give people that toolkit. Our curriculum will, in fact, have a bystander, upstander training section. We didn't create it. We're just putting the best out there. The best on the planet is anything from Fineway. They are the end all be all, but I think we can do it better. I'm a little competitive by nature. Being an ally like Lauren Roth is so important. We joke a lot in our community, but it took allyship to get the Marriage Act passed. It took allyship to eliminate me being fired for being gay. There are more hetero people than there are on the spectrum. And so we need that allyship to make forward progress, positive forward progress. It is important. And so the things we do, again, as we've talked about, are teachable moments. You doing this is huge. You giving this grand rounds is huge. It shows your learners you care, shows your faculty it won't be tolerated in any other way. And ultimately, it will show your patients at some point you're competent. And that's pretty amazing. So as we go through things, keep in mind, assess your own values. They're not wrong. They just may need to stay in your head sometimes as we move through the world that we live in now. Your program, your department, and your clinic at all times should be a zero tolerance zone. If it's not, it's on you to change that. Use inclusive language. Here's the thing, we all make mistakes, okay? Even us in our own community. I don't necessarily misgender, but I often have a hard time with they, them. And so if you make that mistake, just be real. Hey, I am so sorry I misgendered you. Let me try again. And then actively try again. Schedule these training sessions. And like Dr. Roth said, keep them continuous. You have new residents every 1, 2, 3, 5, 6 years. Doesn't matter your specialty. Make sure you're sustaining your training. Keep this in your current curriculum. We're happy to let you beta test our curriculum when it drops in May. Allow actual people in the community to be a part of your panels. It's very important that you have representation. We have a lot of gay straight alliances. That's what they used to be called. They're called pride groups now here at UT. If you're interested, email me. I'd love to get you into any of them. And you can come be a part of every aspect of our world. In fact, we're having a safe space training in February if you're interested. Think about the social makeup of our community, and for San Antonians, that really means thinking about the religious aspects of being Catholic and Hispanic and on the rainbow spectrum. That really does play a part in cultural competence. So really think about that when you're thinking about your patients. And then including local groups and people like us in your conversations. So I think that's it. Yes. So as we end, we've planted the seed. We've asked you to self-reflect. We've offered you some tools. It takes all of us to prevent these extraordinary numbers of suicide in our community. And so we thank you. We thank you all for your time and for allowing us to be a part of your world. I'm going to stop sharing now. I know we're at the very end. You can always email us, but thank you again for having us. Sorry, Nicole.
You're good. Thank you so much for all the information and for giving us such an important discussion to think about today. I don't know if anybody has any comments or questions. You can feel free to unmute, or you can use the chat box, whatever you'd like to do. I don't see anything in there just yet.
Yeah, Beth, I had a question. It's Mark Nato. So
Hi, sir.
I think that's interesting that you have tried to do some coordination with ACGME as far as curriculum goes. Has any work been done with the ABMS? I mean, because I guess people respond to incentives more than to exhortations. So if it's on the board tests, it might even get some more attention.
Agree with you. So let me call out Dr. Nadow really quick for Dr. Cooper and Roth. He is the program director for family medicine, ex-military, and has done an absolutely incredible job of being inclusive in his residency program. I'll let Dr. Cooper talk about this a little, but we started with the American Board of Pediatrics. So that's exactly what we did on our side, but we haven't gone. And so the EPA actually had to be approved by the larger consortium for it to be core. Now, does that mean they're going to add it to the boards? I don't know. So Dr. Cooper, what are your insights there?
Well, as I said, I had 5 questions on my subspecialty exam. So I don't know about the general pediatrics one, but I do know the ABP in specific switched their content specifications. So instead of it being like, know the top 3 causes of bacterial pneumonia in a child, it just says pneumonia. And so it really trimmed them down, which I think is a disadvantage because it doesn't give you any specifics. So there is a category that says sex and sexuality, gender, and something else are in the same thing, but like, what does that mean? And like, how am I supposed to do that? But I can say I write practice questions for the PrEP, which is the ABPs and AAPs practice board exam series for residents and subspecialty fellows. And so for adolescent, we actively write questions about or incorporate people of various genders and sexualities into the STEM, because again, like gay people get knee injuries. And so you can write it in where it's relevant. Like we don't make it irrelevant, but when it's relevant, you can write it in, or if it's just, you want to be nice and say that they have a boyfriend instead of a girlfriend. And so I think you're correct. And I think pediatrics is looking at that. The ABP is a large beast to conquer in terms of the real exam, but they're doing it as evidenced by my particular test I took that year.
Do you want to help us, Dr. Nadow? You want to take on the ACGME with us?
I'm going to get on the phone with the ABMS as soon as I get off this call here.
Conference man, I'll be there. I got your back, sir. No, and you're absolutely right. And so I think we often talk about why, hold on, let me start over. Often when we give this talk, we're said, like, what kind of CME are we going to get for doing this? Or can we get a publication, or can we test? But you're right. And fundamentally, medicine is based on outcome, right? It's like, what can I get for the time that I'm giving you? Whether that be pay or time or credit, because you are stretched so thin. And so we did have to go for the carrot. As much as we want like humanity to be your carrot. We do realize that CME, ethics credit, board prep, and that's, I think, why we kind of went the EPA route to say, this isn't just peds, this isn't just family med, this is everybody, and ACGME is considering these EPAs as a transitional, this. Are we going to do, milestones or EPAs? Maybe we can start the training there, and then if it becomes a requirement to learn, it then often will make it to a board and become a question. So that's kind of the hope. But make that call, sir, and let me know how it goes. Thank you for your question, though. Anybody else? I know you guys are so busy. And
Great
thank you.
talk. I really appreciate it.
Thank you, Dr. Nadeau. You're amazing. I love working with you. For all the rest of you, I just want to tell you thank you. I know that working is hard anyway, in general, but working through a pandemic is soul crushing. And so I want to acknowledge you, and I want you to know that those of us in the world really appreciate your time showing up and caring for people without fail all the time. But make sure you take care of yourselves as well. Please fill your cup back up.
I have a quick question. Sorry, Dr. West.
Yes.
You mentioned something about the safe space training.
Yeah.
How do we join that, and how can we get more information?
Sure. So I'm going to put my email in the text right now. So I'm one of the Pride mentors for the medical school. And I don't know if you know this. I don't know if you went to school here. I don't know much about you, but they rely on our medical students to give safe space training to all of our other medical students. And they don't vet it. So the last safe space training I went to was 312 slides, and they were given 20 minutes. So imagine, right? So instead, one of our goals was to set up formal train the trainer courses with Pride Center. So they're going to come in. We have 40 slots total, and they're not all filled, so it will fill quickly. And when you leave, you'll have a certificate, and you'll be certified to train safe space appropriately and with accurate information that isn't 312 slides long. It's a 4-hour training on February 19th. It's a Saturday, because we know doctors don't work on Saturdays, right? I'm joking. It was the only day we could find. So I'm going to put my email here, and just email me directly if you're interested in signing.
Thank you. I will.
Of course. Have an awesome day. All right. You guys are amazing. Thank you so much. Thanks, Lauren.
Thank you all so much.
Thank you. This was great.
Of course, Nicole, if you need anything, please let us know.
Okay, I appreciate it. I hope everybody has a great day today. Thank you.
Absolutely. Bye, guys.